Hi everyone and welcome to the Emergency Physicians ECG course. This is Hesham Ibrahim. I'm one of the emergency medicine consultants in the United Kingdom, and today we're going to be discussing case number 7 from our Facebook page. Because this case is quite a long case, so I've decided to split it into two parts, and today we're going to cover part 1 of this case. So the case that we're going to talk about was about a 7-year-old female presented to ED with intermittent palpitations and some query pre-syncopal events. She's at normal observations on arrival to ED, and the clinical examination of her was absolutely fine. So she's had an ECG done. This was her ECG. So I don't know how you feel, guys, but I think many of us find the, especially those of us who works in adult mainly side of the ED, seeing kids is quite scary. And if we add on top of this that it is a pediatric ECG situation, which is something that we don't do that often compared to the adult ECG, then definitely many of us will feel very uncomfortable interpreting pediatric ECGs. So why don't we leave this case as it is at the moment, and let's move on to the adult side. Let's talk about a different case. Let's talk about a situation where you've been asked to review an ECG of a 20 years old female patient presented to ED with shortness of breath. So this was the ECG. So what do you think about this? If you look at this ECG, it is clearly an abnormal one, and there are so many points to be concerned about. To start with, the rate is quite fast, and I can see only one P wave before each complex. So this is a narrow complex regular tachycardia with one P waves, that's sinus tachy. Looking at the axis, if we use the way that we've used recently, so if you look at lead 1, you will notice that the complex in lead 1 is pointing down. Sorry if my drawing is that bad. So that is pointing down in lead 1, and if we look at AVF, the complex is pointing up. So actually my right hand is up, so that is a right axis deviation. If we look at V1, we've got a tall R there, so that is a right bundle branch block picture. So we've got an incomplete right bundle branch block, we've got a right axis deviation, we've got sinus tachycardia, and looking at the T waves as well in the right precordial lead, so V1, V2, V3, it's inverted there. So everything is pointing towards pulmonary hypertension picture, and in the context of ED, acute pulmonary hypertension means probably acute pulmonary embolism. So this is an ECG that if I see it, I'll be thinking that's a PE case. So sinus tachy, right axis deviation, right bundle branch block picture, and T wave inversion and V1 to V3, that sounds very PE to me. But what if you know that this is the ECG of a 2-month-old girl rather than a 20 years old girl? Would that make any difference in your head? So let's talk about a suggested approach for pediatric ECG interpretation. Last week we've talked about the adult one, and this week we're going to talk about the pediatric one. And guess what? It's exactly the same approach. You're going to look at the complexes, you look at the QRS, and then ask yourself 4 questions. What's the rate doing, rhythm, width, and axis? Then you're going to check the P waves and its relation to the QRS. Then you're going to check the intervals, and I mean by this PR interval and a QT interval. Then you're going to have a look at the chamber enlargements, so atria and ventricles. Then you're going to check for ischemia, so you're going to have a look at the ST segment, T waves and Q waves, and lastly, anything else. So this is the approach that we've used before for adults, and this is the approach that we're going to use for PEDS ECG as well. It's exactly the same. All what you need to be aware of is actually what's normal for kids and what's not. So 2 big things to be aware of. First, that the normal values are different. So there are special consideration in terms of what's normal in terms of the values for pediatric ECGs compared to adults. And the second important fact that you'll need to be aware of is actually in neonates and infant, the right ventricle is the dominant one. So it's thicker and bigger than the left ventricle. and by time the left ventricle gradually grows and dominates. And this is simply all because of this, the fetal circulation. So it's all about understanding the fetal circulation so you can understand exactly what happens with the pediatric ECG. So let's start from here. So this is the placenta. So this is your starting point. The blood is going to go down this route. So that is the umbilical vein going up to the ductus venosus. And then it's going to go to the right ventricle. So that is the good blood going to the right ventricle this way, and from the right ventricle, some of it is going to go through foramen ovale, and then some of it is going to go to the right ventricle, from the right atrium to the right ventricle. And then the right ventricle is going to contract to push it through the pulmonary artery. And the pulmonary artery is going to try to send the blood to the lungs. But because the lungs are both out of action because they're full of fluids with significant vasoconstriction to the pulmonary vessels here. So actually, this high pressure system is not going to allow the blood to go there, and that means that most of the blood is going to go through the ductus arteriosus to the aorta to supply the rest of the body. So now you would understand why we've got this high pressure system in the right side of the heart, which will make the right side of the heart bigger and thicker than the left side of the heart, because your right ventricle is actually supplying blood to the whole body. It's acting as the left ventricle in the adults. Because of this, you get a thicker, bigger right ventricle compared to the left side. So, first thing to be aware of is that normal values are different and they change with age, but generally speaking, the younger the faster. So kids are normally faster than adults. So that's regarding the heart rate. Second, all intervals and durations are shorter than in adults except the QT. So the normal PR interval is less than 160 milliseconds, so less than 4 small squares. For adults, it's 3 to 5. The QRS duration is less than 2 small squares. The QT is the only thing that is longer in peds than in adults, and normally it can be up to 490 milliseconds. That's up to the age of 6 months. Moving on, so as the right ventricle is the dominant one, and we've just explained why, that will result in few things. You're going to get right axis deviation, and you're going to get a picture of incomplete right bundle branch block. So that will be in the form of either a tall RMV or V2 or RSR dash. Then by time, the left ventricle will start developing, and gradually the axis will improve or will change, let's say, to be a normal axis. There are some pseudo ischemia signs. So there will be small Q waves, usually less than 5 millimeters, maybe seen in the inferior leads and lateral leads in peds. And there will be the T wave inversion from V1 to V3, and they can stay up to the age of 15 years old, and they're called juvenile T wave pattern. You need to be aware about a couple of things. First, that the T wave in V1 starts upright, that is just for the first 7 days of life. Then it's inverted. And it stays inverted up to the age of 7 years old. So it's inverted from 7 days old to 7 years old. If you see an upright T wave in V1 to V3 before the age of 7 years old, that could be a sign of right ventricular hypertrophy. So if you see an ECG that you would call normal for an adult, so upright T wave in V1 to V3, that is very abnormal if we're talking about the age from 7 days old to 7 years old. Second thing to be aware of is actually this T wave pattern can be persistent beyond the age of 15 years old, and it's called, in that case, persistent juvenile T wave pattern, and it can extend to the adulthood life, and usually that will be in the Afro-Caribbean females. So more additional leads you will need to be aware of and to add it onto your ECG when you do it. So you need to cover the right side of the heart, and you need to cover the posterior side of the heart. So additional lead might be required. Some people talk about moving the leads. So taking V4 out from here to there. So at least it's going to give you a window of the right side of the heart in your 12-lead ECG. So if we go back to our patient that we saw, I'm talking about the ECG, not the first patient we've talked about, but the ECG that we've talked about before. And our impression when we thought that this is a 20-year-old female coming with shortness of breath was actually we've got right bundle branch block, we've got right axis deviation, we've got sinus tachycardia, T-wave inversions from V1 to V3. These are all signs of acute pulmonary hypertension, so that's a PE. But if you know that this is actually a 2-month-old, that means simply that this is all normal. This child has got a thicker right ventricle, but not for a pathological reason. It is simply because he's just still too young and the right ventricle is still the dominant ventricle. So this ECG is completely fine from the age point of view if it's for a 2-month-old. So in summary, we've talked about an approach to pediatric ECG, and the approach is exactly the same as the adults one. So when you look at an ECG and find many signs of pulmonary embolism, this is either a pulmonary embolism case or this is just a normal ECG if we're talking about a child. All intervals and durations are shorter in the pediatric side compared to adults except the QT. It's normally slightly longer in peds. And regarding the approach we've talked about, it is the same as the adults. So you check the QRS for rate, rhythm, width, and axis. Then you have a look at the P wave and its relation to the QRS. Then you check the intervals PR and QT. And then you check for chamber enlargements, atria and ventricle. And then you check for ischemia. So you check the ST segment, T wave and Q waves. And lastly, anything else. So back to our original case then, case number 7. So the case was talking about a 7-year-old female presented to ED with intermittent palpitations and pre-syncopal event. She's had completely normal observations and normal clinical assessment, and her ECG was this one. So I'm afraid I've spent a long time talking today, so I'm gonna stop at this stage, and hopefully next week we're going to continue with this case, and I'm going to tell you exactly what happened to this patient, and we're going to interpret the ECG and cover a different topic via the same ECG. So till I talk to you very soon, hopefully, stay safe. Thank you.